minute to discuss with you the concept of delayed sequence intubation. I want to talk to you about what it is, why we're going to do it, why we're switching in this direction, what it means, what the implications are, how we do it, all the things. Okay, so this is going to be your 5-minute tutorial on delayed sequence intubation for the paramedics. So what is delayed sequence intubation? Well, its cousin is rapid sequence intubation, which you're used to, and the idea is very similar. So in RSI, the idea is that we give somebody an induction agent while we're hyperoxygenating them, and then as soon as we can, we paralyze them and intubate them. The idea with delayed sequence intubation is that when we do this, we're going to relax somebody via ketamine. And ketamine we are going to choose because it's good for blood pressure, it's good for the heart rate, it's pro-adrenergic, and then it's going to help people relax well enough for us to take our time with pre-oxygenation. So the big difference is the length of time for pre-oxygenation. So we're going to pre-oxygenate. We're going to do that either through high flow mask, high flow nasal cannula, or this is a little different. We can put them on BiPAP and let them kind of ride the BiPAP while they're in their little ketamine-induced coma while we get our equipment ready, while we oxygenate them and get them ready for intubation. And here's something I want you to think about. You know, I keep saying oxygenation, right? So we talk a lot about this idea of pre-oxygenation, right? And trying to do with pre-oxygenation? Well, you know, our number one goal is to increase the apneic time. Okay, and that's why I like you to use a high flow nasal cannula with it, is because I want to do everything we can to increase the amount of time that the patient can tolerate apnea. We know because there are two independent predictors and outcomes airway. Okay, so one predictor is that we let their oxygen level drop, right? So we allow hypoxia. The other predictor is if we allow hypotension. Okay, so this has been borne out pretty well in the head injury literature, that if we allow either one of those things to happen in our head injured patient, we are absolutely going to increase their risk of morbidity and mortality. Well, it's my opinion that if we allow patients to be hypoxic while we're intubating them, then what happens? We have to stop what we are doing, we have to bag them up, and then we have to try again. Well, every time we try to intubate, we increase the risk of something bad happening. And those things include aspiration, right? So aspiration pneumonia, ventilator-associated pneumonia. Or how about cardiac arrest? We don't like cardiac arrest in this situation. We don't like our patients to die while we're intubating them. And so one of the things that DSI does is DSI addresses this idea of preventing hypoxia by giving us plenty of time to make sure we hyperoxygenate our patients and flush the nitrogen. But the other thing is, since we are using ketamine, ketamine does a couple of things for us that help us in this situation. Number one is ketamine increases blood pressure. Number two, ketamine increases heart rate. And number three, ketamine causes bronchodilation. Okay, so that's going to actually help us to pre-oxygenate. The other thing that's cool about ketamine is, let's say this is an airway where you're afraid to paralyze the patient because of anatomical abnormalities, or maybe they've got, you know, bad anaphylaxis, or they've been burned or whatever, and you just look at it and say, I'm afraid to paralyze this patient. The literature supports using ketamine for medication facilitated intubation. Okay, and of all of the choices, ketamine is probably the best medicine for medication facilitated intubation. So that's medicine, that's intubation where we give medicine for induction / sedation, but we don't paralyze the patient. But ketamine, you remember, it's got pain medicine properties, it's a dissociative anesthetic, it's pro-adrenergic, and so you may very well be able to intubate without paralyzing. And in my personal practice, ketamine is my drug of choice for that situation. So let's just take a second to kind of go through this protocol now that we've talked about why we're doing it. Okay, so obviously, just like with RSI, we're going to have everything prepared. The one thing I would say about DSI is I'm going to go ahead, I'm going to get the ketamine in, I'm going to put them on their high flow oxygen or their CPAP or their BiPAP, and then I'm going to go ahead and get my equipment out, right? I'm going to give them a minute to oxygenate while I'm getting all my stuff together. So if you want, you can be doing number 1 and number 2 simultaneously, okay? And then you see this thing about pre-oxygenation here. Okay, we want pre-oxygenation to be at least 3 minutes, and I would consider making it longer. Okay, I want you to really be waiting on appropriate oxygenation. And your goal, whether we do RSI or DSI, your goal is always 100% of the time to ask your question, how high can I get this patient's oxygen before I paralyze them? And once you get them to that level, you want to leave them there for a minute. Okay, you really want to hyperoxygenate them. So if the answer is the highest I can get somebody is 92%, I'm going to get them to 92%, and then I'm going to let them stay at 92% for a minute or so before I go ahead and paralyze them, right? So I really want to do everything I can to maximize the oxygenation. The other thing we've talked about in the past, patient blood pressure is less than 65. They have an increased risk of cardiac arrest at the time of intubation, of paralysis intubation. And the reason for that is we take what is normally a negative pressure process and we convert it to a positive pressure process. So if you already have low blood pressure and you turn it into positive pressure, so you're decreasing preload, well, guess what's going to happen? Blood pressure is going to get worse. The other thing is if somebody's hypotensive, right? So when you think hypotension, you should be thinking about shock. And one of the things we know happens in patients with shock is they get lactic acidosis, and so your patient's going to be acidotic if they're hypotensive. So if I paralyze somebody and I cause a respiratory acidosis and I put that on top of their metabolic acidosis, guess what's going to happen? It's going to be increasing acidosis, and we know that that kills people. So we want to maintain some normotension before we intubate our patient. So if that's the case, we can make the so-called push dose epi, and we can give 10 to 20 mics every 3 to 5 minutes. Okay, the new literature on intubation, what it really says is you must 100% of the time resuscitate before you intubate. Okay, if you remember nothing else from this, is resuscitate before you intubate. And that's how we avoid the clean kill during the intubation. Okay, so once they're oxygenated, once their blood pressure is good, once they're resuscitated, and that might mean you need to give some normal saline through here as well, then and only then do we paralyze the patient. Okay, let me say that again. Not until resuscitation has taken place with pre-oxygenation, fluids, push dose epi, do we paralyze the patient and then go ahead and intubate them. Okay, we obviously want you to use video laryngoscopy. We know that this is better. It increases first pass success. We know that increased first pass success is the way to go. So I definitely want you using video laryngoscopy. Okay, and then after you intubate them, of course, you're going to confirm placement with end-tidal CO2. Okay, it's mandatory. It's not an option. End-tidal CO2 confirms our intubation. So post-intubation management, we want to continue focusing on their blood pressure. So that might mean that you continue doing a little bit of push dose epi, or you could consider making an epi drip. And an epi drip is simply 1 milligram of epi inside 1 liter of fluids. That's going to give me a concentration of 1 microgram per milliliter. Okay, and then we can just titrate that to effect. Okay, we want to maintain a MAP greater than 65 when at all possible. Once we intubate, obviously it's very important we keep our patient adequately sedated, and so we can use ketamine for that. Of course, you have access to Versed, which you changing in this new protocol. So just some things to consider, right? If you have somebody with a known allergy to any of the medicines, if somebody has a airway obstruction, massive swelling, stridor, these are patients that you don't want to paralyze, but these might be patients that you can give ketamine to and do a semi-awake intubation with your video laryngoscopy. Okay. Remember, ketamine is not a paralysis drug, a paralytic. And remember, succinylcholine does not do anything for sedation or pain control. The final thing is succinylcholine does take 45 to 60 seconds to become effective and provide adequate paralysis, so it's very important that you be patient. Okay, the last thing I will tell you before signing off here is I do absolutely advocate for proper patient positioning. If you properly position your patient, you will increase your chance at first pass success. And then included on this protocol here, we do have just a little bit of a dosing reference chart just to make life easier for you. Keep in mind, for kids, the succinylcholine dose is 2 milligrams per kilogram, whereas for adults, it's 1 to 1.5 milligram per kilogram. And then for kids, for small adults, for big adults, our ketamine is going to be 1 milligram per kilogram. And then down here is a little instruction on how to make push dose epi. The easiest way I know how to do it, and you may have your own way you prefer, is you take 1 milliliter of the 1 to 10,000 epi, so that's your so-called cardiac epi. And then you're going to add that to 9 milliliters of normal saline, and that'll give you a concentration of 10 micrograms per ml. And then when you use your push dose epi, you're going to give 2 to 3 milliliters per dose every 3 to 5 minutes or so. So that's all I have for you on this protocol review. If you have any questions, please